y'all, this is Gwen, and today we're going to be talking about neurostorming or paroxysmal sympathetic hyperactivity and some of the things that we can do that actually help at the bedside. I know many of y'all have taken care of patients that have experienced storming with traumatic brain injury, and quite honestly, they can be kind of hard to manage in the moment. Um, the goal today is to talk about some of the common triggers that cause storming in our patients and do a quick medication review of some of the things that help our patients when they're going through their storming episodes. So let's get started with a case study. So let's say that you are on shift and you're caring for a 24-year-old patient that experienced a traumatic brain injury after a motor vehicle crash. And while you're in doing your nursing cares, like say you're about to turn your patient, you notice that the patient's heart rate jumps to 160, blood pressure, systolic blood pressure jumps to 210. Patient's got a respiratory rate of like 35. You notice that they're sweating on their forehead and their arms and their chest. In fact, their gown is soaked and they're prostrating. They might also, if they're on the vent, just not be in sync with the vent. And as I said, you already recognize that this patient is storming. My questions to you are, what do you assess first? And then also too, what medications are you looking at to help get this patient through the episode? Before we go any further, I wanted to take a moment to just kind of pause and think about what is actually happening to the brain during a storming episode. So we know the brain has experienced injury, whether it's TBI, MVC, and so as a result, the brain's ability to just kind of regulate has been altered. And because of that, the brain is on like is experiencing this sympathetic overdrive. So think fight and flight on steroids. So think of just all of the chemicals that are being released, with fight or flight. So think epinephrine, norepinephrine, things that would make our heart beat faster, a sweat, make us breathe harder. So the body is receiving an abundance, an overabundance, in fact, of these chemicals during these episodes with the brain's inability just to regulate it because of the injury. Okay, so we're going to continue with our case study. So on our case study, we know that our guy is tachycardic, hypertensive, has tachypnea, and is desynchronous with the vent. And our inclination might be to just go ahead and bolus some propofol and to walk away. But I want to challenge your thinking and um, have you to consider, have you looked at what other things might be triggering this storming episode? So we could automatically assume that this patient is in pain, but there are some other things that we might not automatically consider that might be contributing to these storming episodes, such as a patient could have a overdistended bladder, or they might be constipated, or they might be hot. I think about how many times I have had an abundance of pillows in the bed, in the patient's bed, and the patient just gets overheated, and then that causes a storming episode. Um, they could be experiencing discomfort from the vent because the being on the vent is not comfortable. It could be multiple factors, including bright lights, the room being too loud. Sometimes we try to put on that calming, like music on the calming channel. That could be a trigger. The point is, there could be multiple triggers that need to be considered, and we need to see how they are contributing to the storming episode. One of the other things that tends to happen is like once we see a patient is in a storming episode, we tend to maybe just treat with like maybe a dose of fentanyl or maybe Tylenol, and we just use one thing. And then we realize that that one thing really didn't make that much of an impact in managing the storming or managing the pain. And that's kind of the case with these individuals that are going through this. One type of medication is typically not enough to help manage the storming episode. Most of the time you need like a multi-prong like plan of attack to help a patient get through storming episode. So that might be um, so normally that involves like looking at managing and getting rid of the trigger. So if that patient needs to poop or the patient's in pain or turning down the light or making the room cooler. And then the other half of that is the balance of like getting control of that sympathetic surge. So that is looking at medications that are going to either stop or blunt that signaling of like that epinephrine or norepinephrine being released um, and causing the surge. So let's look at some of the medications that are used to help with that. As I said, medications to manage the patient is a two-prong effect. Pain medication alone is not enough. Storming is driven by autonomic dysregulation. So um, let's continue with looking at some of the medications that are needed to manage. So one of the medications that's often used is propranolol. And propranolol is a non-selective beta blocker. And it's really helpful because it's used to help like blunt the body's response to like um, adrenaline and can cross the blood-brain barrier. So it's going to act directly on the nervous system. One of the other things that it's really beneficial in helping with is like cerebral like autoregulation. So it's going to help um, maintain the brain's ability to like regulate its own blood flow. Um, like during periods of like blood pressure fluctuations that are commonly seen in storming, it's also going to help with like neurogenic fever control. So this is helpful, especially when like Tylenol doesn't really help. The other thing that it's really beneficial in helping with is to like in management of like anxiety and like helping with like agitation, like management. Another medication that is used is clonidine. So clonidine is an alpha 2 agonist and it is used to help like reduce like the signals. So reduction of like those signals that are really driving the storming episodes. So it's going to turn down the body's fight or flight response. And clonidine is also really, really helpful when we are transitioning a patient from like IV Precedex to like oral like medications, or we're weaning like propofol when we're trying to get the patient off the vent. Benzos can be really effective in helping symptom management for a patient that is storming. So think of using benzos when you see a patient that is really desynchronous with the vent. They're really having bad spasms. They're posturing really badly. Um, Benzos are great to use as a breakthrough medication to manage those symptoms. One of the things though with benzos is that it really should be considered like as a breakthrough. It shouldn't be the first thing that we reach for. We have other medications and other things in our toolkit. One of the things that could possibly happen with excessive use of benzos is that we can have a patient experience benzo withdrawal, and so then we've now added an additional trigger um, in their storming, you know, uh, for their storming episodes. So um, just remember, benzos are useful for like symptom management and should be used sparingly if possible. Lastly, one of the big things that as bedside nurse can be challenging is educating family on how they can help their loved one right now. It's really going to be important for you as the nurse to really help enforce like what's going to be beneficial. So that would be helping the family to understand like using a calm voice in the room and really creating a quiet environment at bedside. Um, Helping the family to understand that gentle touches are okay as tolerated, but these patients also need like protected rest periods too for brain recovery. So that might be just a really quiet room. That might mean the family member just going and taking the break to allow the patient to rest. Um, you, as the bedside nurse, are probably going to need to reinforce that and help the family to understand that multiple times as they are watching their loved one recover. Just some final takeaways from this little presentation. Just please remember to treat triggers first, to use a multiple prong approach when using medications to treat storming episodes. Remember that more sedation is not always the answer, and that families need coaching on um, simulation triggers. Lastly, here's some additional resources for you if you would like to read more about neurostorming. And also, too, I want to encourage you if you haven't taken Neuro Light, it's definitely a class worth your while. It's 8 hours, it's one day, and I think our next class is in May. So think about it. Thank you for your time.